Everyone agrees the future state looks right. What there's not clarity on at all is the journey to get there. You can't run an operation of that scale in the way you would run a single hospital. It's just not possible.
Meet Shane DeGaris, Group CEO of Barts Health NHS Trust, Chair of the Association of NHS Groups, and Interim Chair of UCL Partners. With 15 plus years of leading major NHS systems, he's driven large-scale healthcare transformation across London. Today, he shares insights on leadership, operating models, and the future of integrated healthcare.
No one's got a veto. This isn't about getting 6 union delegates and they all have to agree. You debate the issue, the pros and cons, and then a view is formed. For many years, I'm very happy for resource to shift by organisation. It's hogging a lot of the resource, but I'm not happy for the resource to shift if the work doesn't shift.
What does it particularly mean to you as a group chief executive of a very large London NHS trust? Thank you very much, Shane, for joining me this afternoon. Shane is the Group Chief Executive of the Barts Health Foundation Trust, has a clinical background and then an experience of executive leadership across a number of trusts, particularly in London, Shane. So it's great that you join me today. So thank you very much for your time.
Thank you.
Obviously, we're thinking about operating models. And I guess when I use the phrase operating model, I'm kind of very mindful it means different things to different people. So what does it particularly mean to you as a group chief executive of a very large London NHS trust?
Yeah, I mean, it's a good question. And it's funny. I mean, we are a group of hospitals, and you'll see that phrase bandied about a lot nationally. And in fact, interesting, I've just taken over as chair of the Association of NHS Groups from Glenn Burley, who's obviously off doing a national role. One of the things we've seen already, even in that association, is you've got different versions of groups. So some are sort of fully merged trusts like Barts Health, they're all free would be another example where all the hospitals are under one umbrella, and others sort of looser operations where they are separate standalone entities but with some sort of shared function, CEO, chair, potentially shared board maybe. So in our position from the Barts Health perspective, we're a merged organisation, have been since back in 2012, and that itself was a merger of other organisations that have gradually come together. So yeah, we've got 5 hospitals now covering a big population in East London, combination of specialist tertiary hospitals to kind of more district general hospitals serving local populations. There's over 20,000 staff, 2.5 billion turnover. So it's quite a huge operation, and in fact, the group you couldn't. I don't think you could run a trust. I was chief executive at Hillingdon Hospitals in West London for 6 years, and that was I loved that. But that was although it was 2 sites, there was only 1 acute site. You can't run an operation of that scale in the way you would run a single hospital. It's just not possible. So we have distributed leadership. Delivery vehicles are the hospitals. They've got their own leadership team. Those leaders, the CEOs of those hospitals, sit on our trust board. So there's kind of a vertical operation going on in each hospital. And then horizontally, you've got clinical boards and leads that connect across to try and drive up standards, reduce variation, and then group support services that works alongside support staff. So it works quite well. There's no one size fits all. That's my experience of talking to colleagues across the NHS.
Yeah, sure. So you've outlaid the kind of basics of how you operate then. I mean, you're a strong advocate of that group model. I suppose 2 questions really. One, what's the problem it's really trying to solve by being a group as against anything else? And why do you think it's so successful or preferred, shall I say, rather than just so successful, because it's a challenging environment?
Yeah, and in some ways, I think part of this is horses for courses. So it works in certain circumstances, situations. And I certainly can't take the credit for the way this group was formed and reformed, should I say. That was my predecessor, Dame Alan Williams, who did a fantastic job coming in. But she came in at a very low point for Barts Health in 2015, post the merger in 2012, and there was serious quality and financial problems in special measures for both. So the problem we were trying to solve then was addressing both of those concerns simultaneously. And when she came in, she discovered that, a bit like I described earlier, that they were trying to run it like you run a single hospital. So you had leaders, and clinical leaders in particular, running, say, a division of medicine, but across 5 separate hospitals. And that was difficult in itself. And the feedback from the staff was, well, they never saw leadership because there was no local leadership. It was all centralised. So that combination of putting some direct hospital leadership back in with some clinical boards that stretched across to drive up standards. I mean, that's the rubrics of it, including quite a big cultural model about how we work together, a big push on quality and diversity. That's a big issue for us in our patch in East London. So quite a kind of cultural OD program that underpinned this team development and team leadership. So it was trying to solve those problems, and it largely has. I mean, we still have, daily grapples about how we work together across the group of this scale, but Barts has been on a very, very steady road to improvement over several years now, and I've got no doubt that is because of a number of things, but largely because of the way the group is organised and how people have responded to it. And I think what I would add is that hospitals, the DGH hospitals in the group, so Whipps Cross and Newham in particular, on their own were basically financially, don't use the term bankrupt, but unable to be financially sustainable, let alone clinically.
Right.
So by stretching clinical networks across hospitals, and also in terms of investment, we're much better able to support a smaller hospital with a much larger footprint of capital to work with. Now, when I was in Hillingdon, it was completely down to what happens in our capital budget. And literally all of it went on preventative maintenance and things like that. So the ability to invest is also much stronger in a group and support hospitals.
So clearly there's advantage for those smaller hospitals. What about something like Royal London, which is obviously prestigious, beautiful new building, lots of specialist services? What's the advantage for them of being in a group, do you think?
There's a couple of things really, and they would say to you that they found it extremely advantageous for their patients and for their staff. And of course, the Royal London is a confusing hospital. On its own, it's probably an 800 million, maybe 900 million turnover hospital. It's a huge thing. We've got a massive dental hospital, massive children's hospital, a whole range of specialist tertiary services, the air ambulances coming on the roof. It's a trauma centre, stroke centre, but it's also a district general hospital for the residents of Tower Hamlets. So it's got to do all of that. And the way it finds the group helpful, of course, is that the more it makes it easier for them to do the high complexity surgery, so kind of like low volume, high complexity, if our other parts of the group can take on that more high volume, low complexity. So patient pathways and the way work is distributed around the group can also help the specialist hospital within this to make sure it's focusing on the right patients as well as its local population.
And in terms of managing flow across the site from an operational point of view, I guess it's relatively easy to say we'd like to flow patients, both elective and emergency, from Royal London to Whipps Cross, or because you're in one I'm assuming those things are much easier.
But easier, no question about it. So if I think about how we can make patients on elective and non-elective pathways flow, it's far easier than perhaps if I have to deal with other hospitals that are not part of the group in our system, even though we're all good partners and we work together. The very nature of those trusts makes it more difficult. So particularly for elective patients, really trying to make sure patients have access to all the hospitals, wait the least time as possible, and at those clinical standards are the highest possible. And definitely in times of emergency pressure, it's easier to arrange some of those pathway changes across our own hospitals.
And have you deliberately developed, elective centres or, other particular services to spread it across the different hospitals? Has that been part of the strategy?
Yeah, absolutely. And that mix, that goes from the very sort of specialist to the sort of the more routine. So obviously St. Bartholomew's Hospital, 900 years old, a few years ago, the biggest cardiac centre in Europe, and also a very large cancer centre. So inevitably leads on cardiac across our group network service. At the other end, we tried to centralise as much elective orthopaedics as we can at Newham Hospital, not all of it, but as much high volume, low complexity as we can there at Newham, because it's configured that way, allowing the more complex cases to be done at the Royal London. So there's quite a synergistic trade-off. I mean, we don't always get this right, and we've got to respect patient choice, of course, and respect that. But I think you'll see increasingly over time, particularly as the left shift kind of kicks in, and we'll probably talk about that later, more of a need to make sure we're centralising and offering that high-quality service at less sites, if you like, in a much bigger hospital footprint, particularly in London, where the travel and geography is not quite what it is outside London.
Yeah, well, and indeed, my colleague's father is due to have his cardiac bypass at Barts tomorrow. So
fingers crossed. Yep.
Yeah, indeed. Indeed. You've identified before that as a group, there are kind of some, you've mentioned capital investment, particularly for smaller TGHs, but and you've mentioned some of the pathways bit, but I guess there are also opportunities really for the workforce, for workforce development, for the way you manage leadership and clinical talent across the group. Did you want to say a little bit about that?
Yeah, so I mean, I guess our size and our scale makes it far easier to move people across different roles in the group, in the hospitals, and kind of progress their career without having to leave the organisation. And we've kind of created structures to enable that with clear development opportunities at sort of entry level right up to senior leadership, talent management that can then be applied, and also layering in our kind of approach to equality, diversity. Just trying to make sure we're getting the right talent, and it's not everyone that just looks like me. So it does mean staff can move between within hospitals, between hospitals, to central roles in the group and vice versa, clinical, corporate, internal pipelines for clinical leaders and operational leaders. And as I say, establishing a talent program that has a much bigger visibility on diversity in those roles. And so therefore what happens as vacancies come up, we've got quite a wide talent pool. We've also got a central education academy that offers broad learning opportunities right from the entry level up to sort of master's levels.
Right.
It's not uncommon for internal appointments to be made across the group. So just a couple of examples. Recently, Simon Ashton, who's my chief executive at Newham Hospital, was previously the managing director of our clinical support services in the centre of the group. And Tris Kerr, who's now the director of nursing at the Royal London, was formerly the director of operations here at Whipps Cross. I'm at Whipps Cross today, and also director of nursing here. So I like the fact that we can offer opportunities and allow people to move in a way that perhaps is a bit less hassle also than trying to go outside in a place that you know where to work. But of course, we don't stifle people from going externally. I'd want to put them in a good spot to do that if they wanted to.
What are the things that you kind of want to keep consistent and standardized, and you'd expect to be the same in each hospital? And what do you allow local variation and to be very much kind of more locally led?
That's a great question, and in some ways comes to the core of what we sort of grapple with intellectually every single day. So, I mean, the principle is that hospitals are responsible for delivering services at their hospital, but that those reflect the standards as a whole across the group, and we're trying to drive down variation and drive things up. And the most obvious point is, despite the fact we have obviously itemised measures for each hospital across all domains, quality, safety, performance, finance, etc., we are one trust. We are therefore measured in aggregate. So their contribution to the aggregate performance of the group, say for 18 weeks or, UEC, whilst we'll obviously track what happens locally and understand that, they have a contribution to the global message about how we're measured as a trust. So I guess in practice, there's kind of a constant dialogue about between sort of executives and the group and the hospital CEO teams, and that trade-off between consistency and kind of local autonomy. So as such, we've got quite a detailed accountability framework for the group, but we keep that under regular review because I think this is one of the ones that I've been CEO now, 3.5 years, and I was deputy here for 4, and that's had at least an annual refresh each year. And we've actually made quite a few changes over that time.
Right.
So I think things evolve, and you can't quite quickly, you can become left behind, particularly as policy and strategy commissioning changes around you. So you have to be agile. That's what we've experienced.
Yeah. And how are you agile when you're such a large organization and a group? I suppose that, if you compare Hillingdon, I'm sure it wasn't easy to change just the one main hospital, one main executive leadership team, as against now you've got to take 6 teams with you across 6 sites and the group level. So how do you maintain agility in a complex organization like that?
Yeah, that's a great question. So I think we don't always get this right. First thing is that, no one's got a veto. This isn't about getting 6 union delegates and they all have to agree. My CEOs, hospital CEOs are on our trust board. They are part of a unitary board. So, like most unitary boards, you may not always agree, but you debate the issue, the pros and cons, and then a view is formed. So the executive function is very in a similar way. So I'm really conscious that we have to be agile and not just constantly go at the pace the slowest, or as I say, allow individual vetoes. That said, richness of view is important. Different views are important. And sometimes we'll say to a hospital, well, okay, if you in some ways you can perform less well on this issue, whatever it is, for whatever reason you're putting forward, is as long as in aggregate we are delivering. And that's some of the flexibilities I've got. In a standalone trust, that wouldn't be an option. It'd be, you got to do this. So I can have trade-offs financially and full in a way that I certainly couldn't have as in running a small trust.
I'd like to get a bit deeper into that. So you mentioned left shift earlier. So part of what I think some of the left shift challenges are going to be is potentially dual running. We've got kind of coping with today's demand and the way we're organised and running services now, and wanting to help get into local community development, more integrated neighbourhood teams working more closely with primary care. And we might see some of the clinical expertise, around long-term conditions particularly, and care of the elderly, kind of maybe more working in and alongside community colleagues. There may be dual running in that. And I don't know how much that again, the group model helps you with that left shift and those changes over time.
Yeah, I'd like to think it will, because we're already operating at a scale that makes it more easier across multiple boroughs and multiple populations. If you step back a bit, your question is important, because I think, so you take the 3 shifts, the 10-year plan,
Yes.
so everyone, I think, has agreed that the current state isn't right. Okay, so these are the issues, that this is the problem we're trying to fix. Everyone agrees that the future state looks right. We should be over here, and less work should be done in hospitals, more prevention, that sort of stuff. What there's not clarity on at all is that there's the journey to get there.
Yeah.
So you'll hear lamented a lot that there's no implementation plan for the 10-year plan. I think that's a bit harsh, but some of that needs to be designed locally, and we have to play a part in that. One of the things about that, I think, is very much this point about transition, and it's transition at a number of levels. So if you take the hypothesis that over 10 years, if this left shift happens as it should, significant resource should move from the acute sector into the out of acute sector, just at its simplest. What's the glide path for that? Because I've said for many years, I'm very happy for resource to shift out of my organisation. It's hogging a lot of the resource of our local integrated care board population. But I'm not happy for the resource to shift if the work doesn't shift. Yeah. And it's very simplest. So I need to better work with partners as part, and I'm hoping that part of this neighbourhood piece, the potential to be integrated health organisations. My hospitals, the DGH elements, are already quite well entrenched in their local boroughs as place-based partners.
Yes.
So I'm very interested about how that work will shift. The prevention work will happen, which will enable resource. But I think there's going to have to be some sort of glide path here that says this is going to take some time, and that there's risk and gain share on both sides. The group enables me then to take a view through 3 boroughs: Tower Hamlets, Waltham Forest, Newham, where my DGHs kind of sit within, but also in aggregate working with other system partners in community mental health and primary care. So again, if I was just a standalone single borough hospital, on one hand, maybe that's a bit simpler, because I've just got to work in that partnership. But I think we might get benefits at scale working across multiple partnerships.
And obviously you're talking there particularly about the prevention, left shift into the community, but I would imagine the digital shift, the analog digital shift, is something where being a group and doing things at a group level would give real economies of scale and economies of kind of expertise almost, I would imagine. Yeah.
Exactly. And so we got a huge enabling infrastructure around digital AI, very simple stuff in the hospital, first of all, eliminating any need for patients to do anything other than use apps and access services, ambient voice technology, things that, our scale and the way we operate, we can do much bigger and faster. So I think we're now the number 1 take up for ambient voice using the Cerner Oracle Millennium system. And that's largely because of the scale we've got, particularly in London, and also the willingness of our consultants and other clinical staff to sort of act in an innovative way. So no, I'm really optimistic, and we've got shared platforms now, shared data platforms across North East London. So this is a massive enabler. Again, if it was 10 different organisations, that would be quite difficult. And also, I think more broadly across London, there's been much more of a collaboration now on single data. This single data as a platform, I think, as it is going to be a huge enabler to what we're trying to do here.
So I can see how your setup really, really helps there. So we talked a little bit about collaboration there with the wider system. And I know in the past, obviously you're a big group responsible for a lot of patients. You still work with BHR, but you've had a group structure with BHR and an acute provider collaborative with BHR and the Homerton at the kind of Northeast London footprint. How does that kind of collaboration inside the group and then outside the group how does that work? Because that must be a bit of a tension or a challenge.
Yeah, I don't think it's a tension. It's kind of a challenge to some extent. I mean, I think collaboration is kind of a founding principle of how our group in Barts Health works. So we have to collaborate across hospitals. Don't always get it right, but when we do, it works really well. Our governance structures are designed to make sure our hospitals do collaborate for that sort of greater good, as I've talked about earlier. So things like clinical networks, clinical boards, operational delivery networks sit across multiple hospitals. So inside, I think that's kind of a fundamental tenet about how we do things at Barts. Now, in my patch, we've got BHAUT, a very big trust in the sort of outer part of London, and the Homerton, a smaller but kind of well-performing trust in City and Hackney. So yes, through our acute provider collaborative, I'm the sort of lead executive for that. My chair, Professor Jacobs, is the lead chair for that. We're just kind of refreshing this now to say, so what are the things that we're important that we do together that add value? And I guess that's in the context where NHS England has been pushing more and more emphasis on individual providers being judged as they are, if you like, as opposed to how they kind of collaborate. I think we all realise, the three of us, that we need to collaborate anyway. We're responsible for a population of 2.5 million people. We know North East London is underrepresented in terms of capital. It's underrepresented in terms of the revenue it gets for historical reasons. So there's something in us working together for the benefits of our population and for health inequalities. But what we want to make sure is that those cross-cutting themes and pieces of work add value and aren't just things we should be carrying on with him. And that's particularly important, I think, for a trust like the Homerton, where they're already well established as an acute community leader in City and Hackney. They work well with their partners. The chief exec, Baz, is already the place leader. So we don't want to do anything that detracts from them carrying on in that direction, but also saying when there are synergies across the patch, and particularly with PHR. And probably the last bit is we obviously share a number of clinical pathways across those hospitals. The Royal London in particular does quite a bunch, as you'd imagine, as the main specialist hospital.
Yeah. So tell me a bit about how clinical leadership works. So obviously you've got strong management teams led by chief execs. Chief execs are on the board, and then you've got your clinical networks, clinical boards across the trust. I'm interested as to how the kind of clinical leadership shows up at that level, and the kind of balance, I suppose, between somebody trying to drive improvement in the way a particular, clinical service is organised, and a hospital, and how that shows up. That kind of matrix piece around clinical leadership.
Yeah, and the matrix model is kind of at the heart of what Barts is, basically already a big group. And I always say to people, if you come here or a trust like this, you have to go to sort of thrive in uncertainty. You're not going to have many direct levers you can just sort of pull and say, go do that. That's not how it kind of works. So it works vertically and then horizontally, as you described. So at Whipps Cross Hospital today, Amajit Junda's the CEO here. He's got his own medical director, nurse director. They've got a divisional structure. So the vertical leadership here is all down to them and what they're doing. They'll make changes. I did a tour of ED today and some of the care and elderly wards. That's all local clinical leadership, what's best for this population, etc. The standards of ED and where variation exists is then picked up through that sort of clinical board across the group. And we want to be driving up common themes. So a common theme is mental health patients in ED.
Yes.
So what are our collective actions on that? Not just with our mental health partners as well, but more broadly. And what actions are specific to the hospital? So for a good example would be, so here, there's kind of a somewhat geographical difference about how the department is configured. So that's a matter for them. But a theme of, too many patients are being conveyed to hospitals for mental health issues is something we can pick up in common. So Matter's not the best example, but I'm just trying to give an example where, the cross-cutting group would pick up the thematic point and the specific point would be picked up in the hospital itself. And really the cross-cutting clinical boards and networks are designed to be more strategic and picking up things, common themes, standards variation, the sort of Tim Briggs girthed world would also be picked up through there. And then the more day-to-day operational piece will be picked up locally. Now that sounds simple, but of course there will be crossover there because you might have a strategic idea here to improve service X at hospital Y, and that may have implications for others. What we don't want is completely different services developed unfettered across the hospitals. That's some sort of central control. So our governance picks that up.
And will those clinical network, those cross-cutting pieces be led generally by clinicians, or I mean, what's it have as leadership?
Yeah. So each clinical board and network, I mean, we're just redoing this now because we thought we had too many networks, but they're all led by a senior clinician that's going to put in post across the group. They sit under the auspices of the chief medical officer, and they've got help from the director of strategy as well. So it's a kind of combination of clinical leadership and strategic oversight.
And I guess, will they also have a leadership role in the hospital, or are they just, so you could be double-hatted for that sort of thing, could you?
Exactly. So we're not prescriptive about it. It's not you have to be one or the other. There are people that are doing combined roles, some are not.
Yeah. I suppose the nature of being a clinical leader is you will have your clinical practice usually based somewhere. So you're almost, it's different from somebody like yourself or myself, where we would be concentrating generally on a leadership role, a clinical, just some sort of managerial leadership role, as against a clinician who are used to having those multiple hats. That brings a different flavour, I guess, to that.
As I say, we're just kind of refreshing our approach to clinical boards and networks now. But the principles are it's a clinical lead that's got credibility across the organisation. They've got some proper management support, backup from informatics data, that sort of stuff to make sure it's useful, and that then plugs into the kind of a broader strategic board. So yeah, but I haven't got a fixed view about what they should or shouldn't be, because in some ways, sometimes the right person is the person that's already doing a leadership role as well. Sometimes it's not.
And the influence on what's happening, as you were describing, there's going to be what's most likely to make a difference with the decisions made. Is it a view and a critical issue picked up by a clinical network led by that clinical leader, or is it a kind of vertical issue about performance in the hospital that the chief execs? I guess those two just have to come together, as you described in A&E, and you have to find a way of making it work for the...
Yeah, I mean, it's trying to connect, and again, an organisation of this scale, you've got to connect the dots, and the dots probably start with what's the strategy of the trust? What are our three most important things we're doing? So, and then it's kind of bottom up, what's the ideas coming from the so-called shop floor, but from clinicians, the hospitals, etc. So what we want is things that are, it's one of our objectives is to, unsurprisingly, is to make sure we've got strong financial stewardship and we can break even and we can be efficient and have clinical productivity. So whatever this idea is, how does it fit into those strategic drivers? How does it fit into the quality agenda? We use quality improvement as our kind of spine, the IH approach. So I'm also always very interested in, so whatever the issue is, what's going to be the quality improvement approach to this? Because we're trying to create a culture of continuous quality improvement in the organisation. So it's just kind of connecting things. But again, I don't want too much of a top-down thing where we stifle innovation, because I think that's the danger of a big trust like this. You could just say, well, everything's going to be decided at the top, or by people that kind of just connect to the top. And I think that's a dangerous place to be, and we haven't got all the right ideas.
No, and I think that probably speaks a lot to the notion that your job is about creating the leadership system within which other people will thrive. And because you've embedded a culture around, quality improvement and a culture, and you've created a simple enough strategy framework that people can go, oh, where does it fit against these things? That people will naturally make the right decisions, hopefully. That difference about creating a framework and a system for people to work in rather than making the decisions is, I guess, part of the difference in your role compared to when you were at Hillingdon, say.
Totally. Yeah, you're trying to create those conditions, but also keep focused on that sort of true north. Where we're trying to get to it. And and its core, we can't forget that we have prime functions around financial stewardship, quality and safety, and constitutional standards that sit within this. And that's the kind of core stuff that we've got to be doing collectively, no matter what anyone thinks. We're obviously a big player in research and commercial developments, life sciences, all sorts of things that are all very interesting. But at its core, that's what we're there for.
And again, I guess being a big group, the opportunity around that whole innovation piece is probably worth saying a bit, because again, I know you've got a very strong, a powerful approach to that. So you want to say a little bit more about what you're able to do as a group there?
I mean, I think there's innovation for us. So there's culture, quality improvement, and there's innovation as part of our broader ecosystem. So we're obviously part of University College London Partners. As a member of UCLP, we are trying to pivot far more to innovation. supporting clinicians, everything from the clinician has got an idea, oh, I think if we did this or I had this product, it could do something and to make things better for patients, right through to the research end. So we're keen to make it easier for clinicians. We're keen that innovation is solving things that aren't problems. It's i.e., so it connects back to our core things we're trying to achieve as a trust. And I'm very interested in innovations and transformations that actually target and benefit my local population, highly deprived population, underrepresented in clinical trials. Yet, in this case, lots of benefits to companies looking to get data and use data. Well, I want that put back into my population to improve health outcomes and reduce health inequalities. So innovation is very much a core part of what we're trying to do. We've got a major vehicle called Barts Life Sciences, which is surrounded at the Whitechapel campus next to the Royal London as an empty land that was sold off years ago, is literally on the cusp of a major investment. A couple of firms own that land. There's about probably 700, 800 million pounds of potential investment going into that Whitechapel basin. We're obviously an anchor tenant for that, or an anchor partner. Attracting industry, attracting entrepreneurs, working alongside our clinicians and researchers from Queen Mary's University and joint appointments we've got. So it will make Tower Hamlets a kind of a global innovation district if it all goes the right way, and it looks like it will. But I don't want that just to be the sake of it. I want that to be ploughed back into my local population and what we're trying to do more broadly. So it's kind of exciting stuff, actually. I kind of need to make sure we've got the right bandwidth on this, because this could be potentially really a big thing for our population over multiple years.
Yeah, and I suppose that's speaking to some of being an anchor institution. I mean, you are, though each of your hospitals will be major anchor institutions, but as you said, the opportunity, the number of jobs and the wealth you must be bringing in to Tower Hamlets in particular, is really significant. So it's, that's exciting. And that's clearly in the mindset, as you've been speaking, is that what contribution are we making to the local population as an anchor institution? Employment in some of the more deprived populations, as we know, because of wider determinants of health, just the creating great jobs, especially if they can be for local people. I guess that's a challenge, is part of what you can do.
Yes, I was going to come on to jobs, because that's another part of our anchor role. I mean, I very much see ourselves as you say, we're a huge employer, and we're a huge local employer. So we've got something called Healthcare Horizons, which works with local schools, local colleges, tries to get local people into education, got apprenticeships, all the stuff. Lots of people are doing this, but we're really trying to focus this on East London. We've also got things like Project Search, where young people with learning disabilities can get fast-tracked into programs and ultimately into employment in our hospitals. And we've been credited for this, as nationally, about how we're trying to do this. So I think this is really important, because there's lots of unemployment, particularly in youth, and we can do our bit, I think, across our 3 hospitals and also in the group to make sure we support that. Some of those benefits I'm hoping will also be magnified by the life sciences development, because that's going to create thousands of jobs as well. So it's probably an even bigger opportunity.
Yeah, no, that sounds really exciting. Watch this space, as they say.
Yeah, absolutely.
I'm intrigued. You mentioned earlier about the adoption of digital technologies and AVT as an example, but what about some of the AI and the atogenic AI opportunities, given your digital platforms and what's there? How are you? I would imagine you're at the leading edge of all of that as well. What are you seeing as the opportunities?
Yeah, no, I'm only laughing because one of the things I want to start with here, and it sounds slightly boring, is that, I've said a few times internally, before we start getting lots of snazzy new software, new things, I'll be actually fully exploiting the ones we've got and the ones we're already paying for. And when you ask that question, you get sort of a few looks, eye contact tends to drop. I think, and we're a good example. So as a major provider with lots of systems, and it's a bit of a wild west out there, of course. You're getting companies all the time pitching, and they're quite clever. They pitch at individual clinicians, and they say, well, just try this, we'll do it for you for free. And then next thing you know, there's some sort of fledgling system going up, which we haven't really put any governance around, we haven't understood. So back to this whole agility and innovation arc. We're trying to make it easier for people to do this, but have some sort of governance around it. So first point, exploit what we're currently not doing, and there are definitely opportunities for that. And secondly, there's huge opportunities around AI, and lots of talk and I've seen various demonstrations. A lot of it's focused on clinical areas, of course, and as you would expect, but a lot in kind of back office and kind of behind the scenes. Now, we already do quite a bit in our people services on automation. And back to our acute provider collaborative point, clearly with the Homerton, BHAUT, and in fact, other parts of North East London's provider infrastructure, I do think there's quite a chance to do a lot around more automation and AI in that space. There's an appetite for this, I think, because on paper it's a bit easier perhaps than going for some of the clinical areas, particularly when you sort of get into, well, does this mean there's going to be less jobs for people? Which I think probably is the answer to many developments we've seen over many hundreds of years about how things evolve and become more mechanized. But what does that mean to the workforce? A long-winded answer, but I think there's quite a bit of opportunity there. I'm quite keen now that we kind of structure it so we're not doing 100 things, we're perhaps doing 5 or 6 and doing them really well.
Yeah, no, that I can see that your setup and I can see that approach would make lots of sense. And Jennifer Dixon did a really good blog recently about adoption of AI, and I think in that she quoted that really it's a socio-technical issue. The danger is it gets thought of as a technical issue, but it's not. It's the socio-technical issue. Because I've had the same conversations with executive teams, and I've said, look, we think from the analysis we've done, here are your opportunities for AI, but can we just check who uses the Copilot opportunities within the Microsoft 365 that you've all got access to? As you say, things go a bit quiet because,
I think that's the point. Exactly. So Copilot's a great example. The other example I think would be, obviously, we're a Cerner Millennium Trust.
yes,
There's all sorts of modules we can buy.
yeah,
Some of which we have. We're nowhere near using the full capability of that existing system, if that makes sense. Some of that's about training, some of it's about awareness, but there's no question we're not going to be able to get to that future we talked about without really embracing the digital approach.
yeah. Yeah. Well, perhaps final question then is just looking forward for the rest of this kind of coming year. What are you really hoping to go after to see if you were thinking, I'm going to shift things in my operating model or how I'm doing things around here? What are the big things you're going after, Shane? And would be helpful just to.
Yeah, no. So I think, as I said earlier, so the group model has evolved over the last 10 years and will continue to do so. As the environment around us changes, we have to adapt. And I think, so the example I'd give there, or my thinking there is that, so with our scale, but with the need to work far more locally at neighbourhood level as part of the changes towards our group model evolve to encompass that. So that's one thing we're thinking through, and we're not sitting in a some sort of dark chamber thinking about on our own. We're discussing that with our partners because that's about partnership. So that's probably one aspect. And I think the second thing is that regardless of how much left shift there is, there's still going to be a need for major specialist services and major hospital services actually in any scenario. How does that clinical strategy play out? How does that work across the group? How does it work with our other acute partners? And we're getting the best value for the taxpayer with the best clinical outcomes. As I say, particularly some of those specialised services where there's quite a bit of duplication across London, actually.
Yes.
And I know that's something that we'll be picking up more broadly across London. So there's kind of how do we make things work better for the neighbourhood side, and how do we look at our specialised services more long term? Within all that, I think, is how does a group like Barts position itself to become an advanced foundation trust and therefore potentially hold an integrated health organisation contract or contracts? Because that's the prerequisite you need to be an IHO. And that the prerequisite for that, of course, is to continue to drive up our operational and financial performance. We'll exit this year breaking even for the first time in a long time. And now we've got a break-even plan next year. Constitutional standards going in the right direction. So strategically trying to get ourselves in the right place to work with our partners in the system and provide that sort of co-system leadership role. So I'm actually quite looking forward to the next phase. I think it's quite interesting. I mean, I hope we try and see it through across the NHS. You and I have been around the blocks a bit here. These things tend to come out in a big fanfare. Everyone gets behind it, and then something happens and things change. But the problems are still there. This feels the best chance, I think, to get that shift back and make it far easier for patients and then about what we're trying to do here.
Yeah, well, an exciting future. Thank you so much for sharing your perspectives and your experiences and been really, really interesting, Shane. Really appreciate that. Thank you very much.